to pharmacology, and this week we are going to be talking about equipment that we use pretty frequently in measuring medications and calculating dosage for patients. So one of the most common ways that we give our patients medication is via a medication cup. So typically most medication cups are plastic. They do have measurements on the side of them to make it easy for you to accurately measure medication. Usually a 30 ml cup. 30 mLs is also the equivalent of 1 fluid ounce. And we use this, we can absolutely use it for our oral tablets and pills that we give, but we also use it to measure our liquid medication as well. So it includes mLs and ounces. So 30 milliliters is the equivalent of 1 ounce, 5 mLs is the equivalent of 1 teaspoon, and 15 mLs is the equivalent of 1 tablespoon. So this is a picture of a medicine cup that we use in practice almost every day. You'll see on the one side that it does, on the left there, show you drams. We don't really recognize drams anymore, so we do our ounces, our tablespoons, teaspoons, and our mLs. We also can see the use of perhaps a calibrated dropper. These come in different measurements as well. We can use these a lot for our pediatric patients to administer medications. We can use it to dispense eye medications and ear medications. They can come in a half of an ml, 1 ml, 2 mLs, I've seen them up to 5 mLs. Some other devices that we can use to administer oral medications, particularly in our pediatric patient population, is this little syringe that we have there on the bottom. We can draw up a predetermined amount of medication after we solve a dosage problem, and draw that medication up and just squirt it into the child's mouth or put it into perhaps another type of a dropper or a medicine cup. And then the top picture there is a spoon that has measurements on the side of it there. You can hold it upright, draw up the amount of medication that you need, and then you can administer the medication to the child through the spoon. So sometimes we will have to give parental medication. So we have specific parenteral medication devices that we use. So this would be the route that we administer medications by injection. So we can give an injection intramuscularly. So if we give it intramuscularly, that means that we're going to give it into a muscle inside the body. We can also give it subcutaneously, which means that when we administer this medication, it's given into the fatty layer of the tissue just underneath our skin. And then we can also give medications intravenously, which is when we give them, they go directly into the vein. Giving medications intravenously allows us to give higher amounts of medication, and it also allows our medications to work quicker. So just some of the devices that we may use, we can definitely use syringes, we can use IV catheters, but we have to make sure that we're calculating our dosage correctly. And then we have to make sure that we understand what are the principles of our rounding rules to make sure that we're providing the correct amount of medication. So this is an example of what we would call a 3 ml syringe. So just looking at a couple key pieces of this syringe, you can see that they're labeled there. At the very end there is the actual needle. The needle is attached to something called a Lorlock syringe hub, and that Lorlock syringe hub will connect to an IV catheter so that you can administer IV medications. The barrel of the syringe is labeled there. You have the plunger, which you can use to pull back and push to withdraw medication and to administer medication. And then you have that rubber plunger tip, which is what we usually use to guide us when we are calculating our dose and measuring our medication. And usually these calibrations are read from the top of the black ring on this suction plunger, and they're going to be calculated in tenths of an ml. This is an example of another 3 ml syringe. So what I want you guys to keep in mind is that there's a lot of different options, a lot of different products that you can use for a 1 ml, a 3 ml, a 5 ml, a 10 ml. Every facility that you work at is going to have their own stock that they like to use. So you will become accustomed to using the ones at your facility. We can also get medications in what we call a pre-filled syringe dose. So this means that this is a one-time use only. Depending on the dose that's ordered, we may administer all of the medication in that syringe, or we may be wasting part of it and only administering a portion of that. And then we discard any medication prior to the injection. So if this was a 1 ml syringe and I was only giving 0.5 of an ml, half of that syringe, I would want to get rid of half of that ml before I go into the patient. Because if that medication is still in there, we have to remember when we're giving that medication that we're only giving half. And it's very easy to get sidetracked and administer all that medication by mistake. So it's a good habit to discard that medication and waste any medication prior to giving it to the patient. We also have syringes called tuberculin syringes, or you may hear them referred to as a TB syringe. These are also used to administer small doses, typically 1 ml here. They're calibrated in 1/100th of an ml. We have insulin syringes, which we measure our insulin in these, and these are units only. So we don't use these for anything else besides insulin because we are drawing our insulin up in units. Then we have our intravenous syringe. So we can use this filtered needle tip here to prepare medication for IV administration. So a lot of times we'll just get a plain syringe that meets the size requirement that we need for the dose that we're giving. We put this filtered needle on top, and then we can draw back medications based on volume. Some of our medications can be a little bit thicker. Sometimes we have to withdraw medications from ampules. Ampules are glass bottles that we break. So we always run the risk of maybe there being a little bit of glass in that medication. So we use these filtered needles to be able to just withdraw the medication without any pieces of glass. All right, so now we're going to move on to interpreting drug orders because this is a big part of a nurse's job. So we are going to be that last person, that doctor talks to that says, this is what I want you to give to your patient. So we have to know if what they've given us is complete and correct so that we make sure we're giving the right medication. So let's go over a little bit of what our responsibilities are. So it is our responsibility to be able to interpret that order and know what the doctor is asking, and if he's left anything out or if he's included everything. After we make sure that that is correct, then we are expected to prepare the exact dosage of the prescribed drug, which means that we have to calculate a dosage problem correctly and administer the right amount of medication. After we prepare our medication, we have to make sure that we have the right patient. So we have to use 2 identifiers to identify our patient. Typically, we use our name and our date of birth. After we identify our patient, we are then expected to administer the dosage that is prescribed by the doctor via the prescribed route and at the prescribed time intervals. After we give the medication, we record the administration of that drug, and then we monitor the patient's response for desired or adverse effects. So we would never go in the morning and give a patient medications without following up within the appropriate time to make sure that these medications worked. For example, if I'm giving a medication for nausea, I'm going to circle back in 45 minutes to an hour to check with that patient to see if the medication I give did resolve his nausea. If I'm giving a medication to decrease a patient's blood pressure, I'm going to follow back in 45 minutes to an hour to see a couple things. 1, did your blood pressure come down? And 2, I want to make sure that I didn't drop it too low, because one thing that you're going to see throughout this course over the next 15 weeks is that we in nursing are always usually administering medications to produce a desired effect, but sometimes these medications cause unintended effects, and we have to be very mindful of that. So it's very possible if I give a patient medication for their blood pressure because their blood pressure is too high, I have to know as a nurse that I know that it's very possible that I could drop their blood pressure too low, and now I have another issue. So this is why whenever we give any type of medication to our patients, we are always going to circle back to make sure that we don't have any adverse side effects and that, what we gave this medication for is working. We also have to be very cognizant of used and acceptable medical abbreviations. Okay, so you will see frequently used abbreviations with our drug orders, but they are standardized abbreviations that are used throughout. So we don't typically in this field make up our own abbreviations and then hope that everybody else can understand what we're abbreviating. We have to know what these are, we have to commit them to memory, and we have to make sure that we only use those accepted abbreviations in our place of work. So some of our common medical abbreviations, and you definitely need to know these for your exam. So IM is going to be intramuscular, IV is going to be intravenous, IVPB is going to be IV piggyback, which is a smaller bag of medication that is our secondary bag. We have sub-Q, which is our subcutaneous. We have SL, which is sublingual, and ID, which is intradermal. We have GT, which is gastrostomy tube. We have NG, which is a nasogastric tube. So these are tubes that go into the stomach that bypass the mouth. We have an NJ tube, which is a nasojejunal tube, which is a tube that goes through the nose into the jejunum. We have PO, which is oral medications. We have PR, which is rectal medication. Then we have the frequency of how we can see medications ordered. So AC means that we're going to give the medication before meals. PC means we're going to give this medication after a meal. Ad lib means as desired or freely, no specific time range. PRN means when necessary. STAT means right now. ASAP means as soon as possible. And then BID means twice a day. TID means 3 times a day, so every 8 hours. QID means 4 times a day, so every 6 hours. Min means minute, H means hour. QH means Q hour. Q2H means every 2 hours. And then so on. So every 3 hours, every 4, every 6, every 8, every 12 hours. The A with the line across the top means before. Your P with the line across the top means after. C with the line across the top means with. S with the line under it means without. And then Q means every. QS means quantity sufficient. AQ means water. NPO means nothing by mouth. GTT means drop. CAP means capsule. ET means end. And NOCT means at night, nocturnal. All right, so we also have to know when a doctor gives us a drug order for a medication, we have to make sure that it has all the right components to it necessary, or we won't be able to give this medication. So typically we want you to be aware that there are 7 parts of a drug order, and you also need to know this for your exam. So what are those 7 parts? So first and foremost is going to be your patient's name. We've got to know who this medication is intended for. Next is going to be the name of the medication that the doctor wants us to give, followed by the dosage. So how much of this drug do you want me to give Mrs. Jones? And then we want to know the route of administration. So how do you want Mrs. Jones to receive this medication? Do you want her to get it through an injection? Do you want her to take it PO by mouth? Do you want it to go IV? What is that route of administration? Then we want to know what time you want the patient to have it, how often you want them to have it, and when you want this order to start. Okay, and then of course our order should always be signed by that licensed provider who's writing the medication order. So it is our job to make sure that that drug order is written clearly. If there are any pieces that are missing that we know are required, any of those 7 parts that we just talked about, it is our job to get in touch with that doctor and say, look, I'm missing this or I'm missing that. Or if you think it's written there but you can't understand it, same thing. We want to call the doctor and say, hi, I'm taking care of Mrs. Jones. I have this order. I'm really unsure exactly how much you want this, you want this patient to have. Can you just do a clarification for me? We never want to make assumptions when it comes to medication administration. So we're going to look at a couple different labels here and look at some important parts that stand out on the labels that you may see in your practice. So one of the things you're going to look at, obviously, is your drug name, okay? So on your labels, you're going to find your brand name, which is your trade name or your proprietary name. This is going to be the manufacturer's name for the drug. It's usually going to be the most prominent name on the label, and it's usually capitalized, okay? The brand name is only sold by one manufacturer. The generic name is going to be that established non-proprietary name, okay? So generic names, if they can make a generic, must be on all of the drug labels. Several companies can sell the same generic medication. When this happens, that's going to lead to competition, which means lower costs for the consumers, okay? So as nurses, we are always going to cross-check our medications to prevent any type of error. So some comparison between generic and brand name drugs, and you do need to know these for your exam. So what are some of the similarities between generic and brand name? So they must contain the same active ingredients. If your Tylenol, your acetaminophen has 350 milligrams of acetaminophen, then the generic brand has to have the same active ingredient, okay? They have to have the same dosage. For example, 20 milligrams or 40 milligrams. They have to be the same dosage form, so caplets or pills. They have to have the same route of administration, which means they would have to, for example, both be oral. They have to be taken by mouth, and they have to deliver the, sorry about that. They have to deliver the similar amount of drugs into the patient's system. So what are some dissimilarities that we can see? They could have different sizes, shapes, and colors. Okay. And it's not uncommon that sometimes when patients come into the hospital, they say, oh, that's not my medication. Mine is a blue oval pill, and we're trying to give them a pink round pill. So we would have to explain to them that sometimes it's a different manufacturer that we have in the hospital, but it is the same type of medication. They might have different inactive ingredients, and the generic costs less than the brand name drug. So looking at these vials here, go through these slides and see if you can pick out what the brand name is and the generic name. So for here, you have Carafate and Sucralfate. So Carafate is going to be your brand name. Sucralfate is your generic name. Okay. My screen is a little small right here, so I'm having a hard time reading that because I don't have my glasses on. Sorry. So it looks like Lanoxin or digoxin. So digoxin is going to be your generic name, and Lanoxin is going to be your brand name. Here we have Pfizer pen. Pfizer pen is going to be your brand name. Penicillin G potassium is going to be your generic. Here we have Biaxin. Biaxin is going to be your brand name. Clarithromycin is going to be your generic. And here we just have lidocaine. We don't have any type of a generic, so we only have the brand name with this medication. All right, we also have to be able to identify the form, okay? So when we think about identifying the form, what does that mean? That this is going to be the structure and composition of the drug, Okay, so is it going to be in a solid form, which means we're going to give it as an oral medication? Is it an injectable? Is it a cream? Is it a patch, a powder form that we're going to break down and make into a suspension? Is it a powder that's going to be inhaled through a nebulizer? We need to know what that form is. So if we look at this label right here for nitrostat, we can see that we have 100 sublingual tablets. So these medications are going to be taken by mouth, and they are sublingual tablets. So here we have digoxin, again, oral solution, okay? This is going to be taken orally. This next one here is going to be aspirin. Looks like we have, again, hard for me to see. This is pretty small. I think it says tablets there. And then here is our inhalation for some of our asthma or COPD medications. All right, here we want to be able to identify the supply dose. Okay, so we want to, this is going to be both the dosage and the form. So the dosage per tablet or the dosage per ml. So what does this mean? So if I see this label and this label were to say 10 milligrams per tablet, that would mean that every tablet that I take out of the container, it's going to be the equivalent of 10 milligrams. That's going to be the strength. So if the doctor ordered 5 milligrams, okay, and every tablet is worth 10, I would know that I would have to administer a half of a tablet to get that. Okay, here for this furosemide, this is an oral liquid solution. And it says right here on the vial that we are going to give 10 milligrams per ml. So ml, again, is volume, it's liquid. We would be drawing that up in our syringe or our dropper of choice. And we would know that for every 1 ml that we drew up, it was the equivalent of 10 milligrams. So if our patient was ordered 20 milligrams of medication, we would draw up 2 mLs because every 10 milligrams is the equivalent of 1 ml. We also need to be able to identify the volume. So the volume is going to be the full quantity that's contained in that bottle. Okay, or that vial. It can also be the number of tablets that are in the container or other solids or the total volume for your liquids. So if we look at this right here, it is going to tell us that this 1 dose of lidocaine contains a total of 30 mLs. Okay, so we might just take our dose that we're supposed to give out of this and get rid of the bottle. We might use this as a multi-use dose, which means we're going to keep drawing up medication from it until it runs out. You'll see a variety of different things. So right here, we know that there's a total of 30 mLs in here, okay? If every patient got 1 ml, we could draw up technically 30 doses, okay? If each patient got 15 mLs, we would only be able to draw up 2 doses. Then we have to identify the administration route. So we talked about this a couple slides back. Are we giving it enterally, sublingually? Are we injecting it? Is it through the ear, through the eye? Is it a topical? Is it an oral? Here we know it's an injection. Okay, so this is going to be an injection medication. And it says it right here, injection. Other things we want to look at, we always want to make sure when we're pulling our medications that we look to make sure that the medication is not expired, okay? Sometimes we also have to, especially I see in hospital settings when we're giving vaccines, pneumonia vaccines, flu vaccines, COVID vaccines, things like that, we have to make sure that we write down the lot or the control numbers in our medication administration record. So lot numbers or control numbers are going to be very important, especially if a medication is recalled. If there was an issue with a medication and it's recalled, this is going to make it very easy to identify that particular group of medication packages and where they were sent to get in touch with the people where these medications were sent to. So a little bit more about the syringes that we talked about earlier. So if you look off to the left here, this syringe has the top of the black rubber stopper lined up right here with the first mark past the 1/2, okay, which follows the number 2. So we have a half, then we have 1, then we have 1.5, now we have 2, and now we have 2.5 plus 1 line after that, okay? So since this is a 3 ml syringe, it has every 1/10 of an ml marked, which means that we are 1/10 past the 2.5, which is going to be a total of 2.6. Over here on the right, we have a syringe that has the top of the black rubber stopper lined up to the 3rd mark past the number 4. This is a 6 ml syringe, and it has every 0.2 ml mark. So that means that we are now 3 of these 0.2 marks past the 4. So that means that we have a total of 4.6. All right, some of the medications that we give are going to be considered controlled substances, okay? So controlled substances are going to be a way for us to classify drugs according to their potential for use and abuse. So what is the likelihood of someone becoming addicted or dependent on these medications? So our Schedule 1 medications are always going to be our highest potential for abuse, and our Schedule 5 medications are always going to be our lowest potential for abuse. Other parts of the drug labels that you may see, there may be a barcode to scan, the manufacturer of the medication, and sometimes a national drug code. All right, another thing you need to know for your exam. So when we're checking labels and we're getting ready to administer a medication, we always have to follow the 6 rights of medication administration, okay? So what are the 6 rights? Well, we have to make sure that we always have the right patient. Then we have to make sure that we are giving the right patient the right drug. We have to make sure that we give the right amount. We have to make sure that that amount is given by the correct right route. We have to make sure that we administer it at the right time. And we have to make sure that we document it correctly. So the right documentation. So when we are doing our, medication checks to make sure that we're doing our 6 medication rights, we can check that drug label against the medication on our MAR. So this is an example here of our medication administration record that we would find inside of our charts at work that we are signed into for our patients. We're always going to check that drug label and then compare it against our MAR before preparing the medication. We're going to do it again after we prepare the medication, and then we're going to do it again before we administer it. So we're going to do our 6 medication checks that we just talked about on the previous page right here. Right patient, right drug, right route, right amount, right time, right documentation. We're going to do this 3 times. The first time before we prepare the medication, the second time after we prepare it, and then the 3rd time next to the patient in the room before we administer it. We also have to be cognizant of any different labels that we see that give us specific instructions for how we need to handle our medications. So they might have different warnings on them. So some of the things you might see is that refrigerate. Okay, some medications have to be refrigerated. Some medications need to be stored in a dry place. Some have to be protected from the light. So you just want to make sure that you're always putting these medications back where they're supposed to be and following any directions on the medication. Sometimes we might have to give medications that have been reconstituted, okay? So some medications may be reconstituted and dispensed already prepared for use, okay? So that means everything's been prepared by pharmacy. All we have to do is shake well to make sure that all the components are mixed, and then we have to read and follow all the drug labels carefully. So now we're going to talk a little bit about preventing medication errors. So when we think about medication errors, the Institute of Medicine has said that about 10 to 18% of hospital injuries are going to be attributed to medication errors. 44,000 to 98,000 people die in the United States every year because medication administration errors are made. This costs companies upwards of $3.5 billion or more annually because of medication errors. So what happens, what is the effect of medication errors? So definitely increased length of, at a minimum, the least scenario would be that the patient has to, increase how long they have to stay in the hospital. It's going to be an increased cost for the hospital because the hospital is going to have to ensue that cost, and it can cause patient disability and even death. Okay, many times, like we said on the slide previously, almost 100,000 people die every year because someone gives the wrong dose of medication. Okay, and then of course, because a nurse is the one who's giving the medication, it's going to be a detriment to our personal and our professional status. It's going to decrease your confidence and your practice. So again, we need to know those 6 rights of medication administration: the right patient, the right drug, the right amount, the right route, the right time, the right documentation. If we do not see everything that we know is needed in that medication or that drug order, it is our job to clarify it. We can't make assumptions. We can't try to decipher their handwriting. We can't say, oh, it must be this amount because this is how I commonly see it ordered. We have to stop. We have to get to that prescriber and make sure that we clarify any incomplete orders. We have to identify the scheduling of doses. So how often are we going to give this medication? So for example, you'll see that some patients in the hospital will get prophylactic doses of heparin. Heparin is a blood thinner, and when you are admitted into the hospital and you're sick, you're at a higher risk of developing a blood clot because you're not moving around as you normally would at home. So we give heparin typically every 8 hours in the hospital. However, it doesn't mean that even though it's ordered every 8 hours, that it was given 8 hours, because sometimes medications are given late in the hospital. So it is our job, when we see that a medication is ordered at multiple intervals during the day, we have to go back to see when it was previously given to make sure that we're still in that required window, okay? We have to make sure that we read over our MAR at the beginning of each shift for every patient. We have to make sure that we verify our times scheduled with that ordered frequency. And then we have to make sure that we review all of our medications to make sure that there's no type of inconsistencies and that there's no possible drug interactions with any medications that we're giving. So our medication administration record, now you would see this mainly, maybe unless you were working in a long-term care facility, most of these are electronic and they're in a computer, okay? So we use our 3 checks to ensure safe medication administration. So looking at that drug order, making sure that we give that correct dosage, and then making sure that we always record it in the computer, because if we don't record it, then anyone can come behind us and assume that it wasn't given because it's not documented. So with prescriptions, we understand that there are licensed providers that prescribe these medications, and they have the authority within their state to write their prescriptions, okay? So we play a very important role in preventing these errors, but we don't prescribe medications, so that's not our scope of practice, okay? And sometimes, depending on the setting that you're in, you may get verbal orders. They might not always come as a written order or something in the computer. So it's even more important when you get a verbal order that you repeat back in real time exactly what you heard and verify that all those verbal orders are accurate to make sure there's no mistakes. So verbal orders, we want to write or enter our verbal orders or our telephone orders into our patient's medical record so that we have proof of them. We always read back to the prescriber to ensure that the order is clear. And then we get confirmation from the provider that the order is correct. Okay, so verification is required by the Joint Commission. They say that we have to do this. So what would that look like? Dr. Jones, I hear that you have ordered 25 milligrams of metoprolol, PO, as a one-time dose starting at 6 p.m. tonight, Tuesday, September 2nd, 2025, for Mrs. Jones in room 4263. Is that correct? That's how we would make sure that we are confirming a verbal order. So just to recap, what are those 7 parts of the drug order, which you do need to know for your exam? That's going to be your patient's name, the date and time of the order, the name of the drug, the amount of the drug, the route, frequency, or the administration schedule, and your prescriber's name and license. Some things that we never, ever want to use, okay? So we don't use a capital U for units. We type it out, okay? Unit as one word. We don't use IU, which is an international unit, and then we don't use capital letters for, Q daily or Q every other day. And this is very important too. We never, ever put a trailing 0 behind our dosage calculation. So if we're giving 5 milligrams, we would write it as 5 mg, not 5.0 mg, because if we don't put that decimal point so that it's completely clear to everyone, that could be mistaken as 50 milligrams, and that would be a medication error. So we never put a trailing 0, but we always have to put a leading 0. So if we're giving 0.5 of a medication, we would always put 0.5, okay? Because again, if we don't have that decimal point clear for everyone to see, then somebody might think it's 5 milligrams instead of 0.5 milligrams. Morphine sulfate. So we do not write MS or MSO4 because you can see the comparison here between morphine and magnesium. They look very, very similar when we first look at them. So we try to avoid using those abbreviations because they can be easily looked at as another type of medication. Okay, so when we are getting medication transcribed, again, we want to know the patient's name, the date and time when it was written, the drug name and dosage, the route of administration, the frequency or time of administration, and the prescriber's signature. The right drug, check medication label. The very first time we come in contact with this drug, we are going to be reading that medication label. Then after we do that, prior to measuring it, so counting our pills, withdrawing liquid, or pouring medication, we're going to check that medication label again after we obtain the drug, and then again just prior to administration, okay? We always want to make sure that we do this in an area that is free of any distractions because we do not want to make a medication error. This is an example of a medication label that you will probably see more so in an outpatient setting. So this is what a medication label would look like if you picked up your prescription from Walmart or CVS or something like that. So we don't typically see all of this per se in the hospital setting because it's just usually single doses, but this is something that you would see in the outside in the outpatient setting. So you have your prescription number, the patient's name, any directions for use. So take 1 capsule by mouth daily as needed. And then here's some special instructions. Take medication with an 8-ounce glass of water, total amount of pills in the prescription, and if they have any refills remaining. All right, so right route. We need to make sure that we always consult a drug information source to confirm the correct route, okay? If you are giving a medication that you've never given IV and you've only given it PO, let's go to that drug book and look and make sure that this medication is in fact ordered to be given that route, if that's okay to give it that route, and then always clarify with pharmacy. Sometimes we may need to change or clarify the way that we're giving a medication. For example, maybe a patient is ordered to have Miralax. Okay, Miralax is a medication that we give for constipation, and typically it comes in a powder form, and we mix it with about 8 ounces of water or juice. So if for a patient that is not taking anything by mouth, we would say that they're NPO. If they were NPO and not allowed to have anything by mouth, would we, even though we had an order for this medication, want to give them anything orally? Maybe, maybe not. We can't just assume that we would want to give that. So we would want to follow up with the doctor and say, hey, I see that Mrs. Jones is NPO because she's having a surgical procedure in a couple hours, but all of her medications are ordered for PO to be given by mouth. Do you want to change the route that they're ordered? or do you want me to give them? And a lot of times it is okay for them to take those oral medications in the morning with just a small sip of water, if we're talking pills or something like that, okay? If we have medications that are going to be given through a nasogastric tube or a tube that's been surgically inserted into the stomach, then the route should not be ordered as PO because it's not going to be by mouth. It should be by G-tube, okay? And then we have to also be cognizant of time-released or enteric-coated medications. So you might have a patient who had a stroke that has some dysphagia and has some difficulty swallowing, and maybe they can't swallow whole pills anymore. So we have to crush their pills and put them into applesauce because it makes it easier for them to swallow. So time-released tablets, we can never crush or cut in half because the patient ends up getting that entire dose of medication at one time instead of over the 12 or 14 hours that it was supposed to be released. And our enteric-coated medications also can never be crushed because they don't break down well when we crush them. So the right patient, we have to correctly identify our patient prior to medication administration. We always want to compare the patient's armband with the medication administration record on the computer. We always want to ask the patient to state their name and their date of birth. If they have a picture, we can compare that picture to the patient, okay? All of these technological advances are set up for us to prevent medication errors. So if I go in and I scan Mr. Jones's label that's on his wrist, but I'm in Mrs. Thomas's chart, it's going to say this is not the correct patient. So what did that do when I scanned that patient? It prevented me from making a medication administration error. So this is why we always scan our patient and we always scan our medications, because these are, protective measures that are put into place to keep us from making mistakes and bringing harm to our patients. The right dose, we want to carefully read and clarify any of our drug orders, recheck labels, make sure that we're making accurate dosage calculations. And if we have very potent medications, we can make sure that we have 2 nurses double check them. For instance, some of our narcotics and maybe our insulin, because these have very adverse side effects on our patients if we give too much medications. And then, of course, make sure that we're consulting drug references to make sure there's no interactions. The right time, we should always make sure that the right time is ordered in that administration order that we get. We always want to make sure that we're giving it according to the right frequency, and we want to make sure that we're using safe abbreviations. Make sure that we're documenting after administration, because we know that omitting documentation can result in over or under medication, because if it's not documented, then it didn't happen. Reminders, we want to carefully double check all of our labels, follow our 6 rights of medication administration, make sure that we are aware of our facility's particular policies on medication administration. We want to check our medication 3 times before we administer it. We want to make sure that we identify that the form that is ordered is what we have in front of us. And if we are unsure about anything, we will always clarify before we administer the medication. All right, so oral doses of drugs. So how do oral medications come? A variety of different forms. We have tablets, capsules, and liquids, very common findings for oral medications. Tablets and capsules are going to be supplied in strengths or dosages in which they are commonly prescribed. Now, it does say here that only scored tablets are intended to be divided. So for NCLEX, I would want you to know that. However, in the real world, you will see that it is completely acceptable to divide or cut a pill that is not scored. So again, one way that we can try to solve a dosage problem is that we want to convert first. We want to make sure that what the doctor wants us to give versus what we have is in the same unit. We talked a little bit about that last week. So if our order says that we're giving milligrams, but the medication that we have is micrograms, then we know we need to do a conversion, because we can't solve any type of problem if we're not in the same system. Okay, so we have to be in the same system of measurement. Then we have to try and think what is a reasonable amount of medication to administer. So I will say that starting out, this is probably going to be very difficult for you because unless work in a pharmacy or you're around medications, you don't really know what a normal dose of metoprolol is. Okay, so the first time I gave metoprolol, if the doctor would have ordered 7,000 micrograms, I might have assumed that that was normal because I've never given that medication before. Now I know that anywhere from 12.5 to 100 milligrams a couple times a day is a normal dose. So if I saw 300 milligrams, I would probably question that because based on my experience now, that doesn't seem reasonable to me. And it doesn't mean that it's not the correct dose. It just means that it's not something that I've seen before. So it's probably something I want to question. So 2 is probably going to be a little bit hard for you at first until you get some more experience. Then we want to go over and we want to calculate our medication. This is how we would do our PO medications, our pills and tablets. So we set up with this formula here. So we put what we desire at the top. So our desired is going to be that dosage strength. So the doctor ordered 25 milligrams of metoprolol. Underneath of that, we're going to put what we have. So this is what we have on hand. Well, the doctor ordered 25 milligrams of metoprolol. I have 50 milligrams of metoprolol in 1 tablet. That's our quantity, our 1 tablet. So then I would divide 25 by 50, and that would give me half. So I'm going to administer 0.5 of a tablet. Okay, so this is going to be just an easy formula for us to use with our pills. Desired over have times the quantity that we have. And I think that is it. This will finish up week 2. Have a great night.